Several years ago, the Society for Vascular Surgery decided to put together a video archive interviewing people who were innovators and leaders in vascular surgery so that their impressions would be available for others to look at, younger people often, to see what the history of vascular surgery was and to see where some of the ideas that we have now came from originally. And today we're in San Francisco at the SVS meeting, and we have with us Jan Blankensteijn, who is a associate professor in Amsterdam and is here for the meeting and is an honorary member of the SVS. And recently it was decided that it would be a good idea to interview the honorary members too, because they bring a different perspective. Often they're not as old, but but they bring an interesting international perspective and have done a lot of interesting things in their own country. Welcome.
Thank you.
So where did you grow up in the Netherlands?
Well, actually I was born in Aruba, so
Born in Aruba.
Aruba is one of the Dutch Antilles, little islands off the coast of Venezuela. But I was 2 or 3 years old, so I don't remember much from the tropics. I grew up in a little town in the south of the Netherlands.
And then, were your parents involved with medicine, or?
Not at all, no. So yeah, the next obvious question is, what led you to your interest in medicine? Not at all. I don't remember exactly when it started, but it was pretty early on at school. When I was interested in surgery. It was sometimes on television, and it was just fascinating for me to be able to operate on people. So when I was 11, 12 years old, I was already highly motivated for medicine.
So you made the decision to go into medicine when you were high school age, or
earlier than that.
And then but then you went directly. How is the system? Is it you go directly into medical training?
It's a little bit different from the U.S. system. We really don't have like colleges. Colleges are part of university, really. So after high school, you go into the university, and then medical school is a 6-year training program at the university. It's totally devoted to medicine. And part of it at the end are, of course, the internships. So the last 4 years, I think, are very similar to the U.S. medical school.
And then along the line there, you have to make a decision about what you might be interested in specializing in, so you can do further training.
Yeah. So your internships, your rotations take you around the various specialties, and it's very similar like here. But as I said, I was interested in surgery. It's not that I never changed, but I always sort of return to the original idea of surgery, and so I've had some other interests, but in the end I ended up in a training program for surgery. At that time in the Netherlands, this was 84, 85, the job market for surgeons was almost closed. I mean, there were too many surgeons they considered, so they shut down the surgery training program for 1 or 2 years, and then slowly opened it up for, I guess in those years, 16 residents or so per year. Now it's a small country, so there were 8 universities. So really 2 residents per year started, and so that was the hardest time for anybody to get a position in surgery. But I was lucky enough with the preparations and the people that supported me, sponsored me, to get such a position in training.
And then where did you do your surgical training?
In Rotterdam. I Started general surgery in the Erasmus University in Rotterdam. For 3 years university segment, and then 3 years in a peripheral hospital, also in Rotterdam.
Mhm.
Yeah, community hospital.
And was that, did that include doing what we would consider vascular surgery?
Yes, so my training started in 1986. General surgery. There was no specialized vascular surgery training at that time. There were some surgeons, especially in the university hospital, that had focused on vascular surgery. But of course, this was well before the endovascular era. Everything was open vascular. And there wasn't much more than peripheral bypass surgery and aneurysm surgery. So most people at that time still had some other hobbies. So you would do trauma and vascular surgery, or GI and vascular. And everything was still under the hat of general surgery. So I was trained a general surgeon. By the time I finished my training, so this is 92, 91, 92, there were people who started fellowships in vascular surgery in the Netherlands. And it was quite loose. There were no like formal training programs, but it was just like, again, so when I finished my surgery training, there were still a lot of unemployed surgeons around. So that 6 years ago, they...
The spigot.
Yeah. So a lot of people were just unemployed, looking for jobs, and one way to find a job was to do a fellowship, like an extra training. So that's how people came about finding a subspecialty in those years. And at that time, I liked vascular surgery, but it was not my main interest. I was doing studies on pigs in the animal lab with transplant surgery. One of my mentors in the university hospital was a transplant surgeon, and he took me to the labs and taught me how to do pigs and transplants and everything, which in the end resulted in a thesis. But it also, of course, dragged me into the transplant surgery field.
So your PhD thesis was in liver transplant. Yes.
Yeah. Liver transplant surgery. Now, a lot of liver transplant surgery is vascular surgery. I mean, it's just vascular anastomosis. So in terms of techniques, it was very close to vascular surgery. But it wasn't my interest in vascular surgery, to be honest, that I ended up doing a fellowship in vascular surgery. It was merely a coincidence. Like many people's careers are based on coincidences. At that time, the University of Rotterdam, the Department of Surgery, had a pretty close link with surgeons at the Mass General.
I see.
And at least 10 surgeons before me had done some work there, like fellowships or rotations or visitors or whatever. One of those friendly links, really. I don't know how that came about, but it was sort of a tradition in Rotterdam to do a fellowship at the Mass General. And this was something that I really wanted to do at that time. And it worked well in my personal life at that time, and I was interested in going abroad, and Boston was very attractive for me. So really my first desire was to have some sort of surgical fellowship in the US, in Boston. And my mentor, Professor Terpstra, who was the transplant surgeon, had also spent some time at the Mass General, so he knew people. So went there, and from one came the other, and I ended up contacting Dr. Abbott. And that's a funny story, but of course there was no place for fellows, and they had a vascular surgery training program at that time, 92, which was 1 year research and 1 year clinical. And there were 2 fellows, and the program was full, of course. But I just remember calling on the phone all the time and telling him, well, I'm a fully trained surgeon and I'm happy to come over and work for you. And there was, of course, no salary, so everything was free. And there was this this click, of course. It needs to, I mean, people need to click, and that worked. So in the end, he agreed for me to come for a year to be an associate clinical fellow at the Mass General. And of course, this was, even though it wasn't a formal vascular surgery training, it was a tremendous addition to my early career. I mean, it was Mass General.
Did you work on research projects as well as working in the operating room with them? Or?
Yes. So so there was one research fellow. He was in the labs, and there were a couple of surgeons who had research programs running in various labs and various topics. But it was only a year, and you'll understand that it takes a couple of months before you're really into a specific topic. So it was very hard to get in those lab studies. But what I did do was chart reviews, simple questions, retrospective studies. I had all the time of the world at my hand. So I did a lot of those studies on carotids and peripheral bypasses. And all of the surgeons at the Mass General at that time were very helpful, and I enjoyed that time very much. And in between those little projects, I always found time to go to the OR.
Did they let you scrub? Were you able to scrub and do some cases there? And
well, doing cases, that's a whole different story. I remember when I got there, it was laid out for me that doing surgery was not possible due to the liability and the insurance and everything. But I was able to scrub and to assist on cases. But I would need a malpractice insurance to cover for like the lowest degree of risks, which at that time was around $1,500 a month. So not having any salary was kind of a challenge for me to cuff that up. Fortunately enough, the Dutch Heart Foundation, I tried to get a lot of funds for this year in the U.S. The Dutch Heart Foundation in the end supported to some extent, but I must say all of the Dutch Heart Foundation money in the end ended up in the insurance pockets, because my monthly allowance was just $1,500 went straight into the insurance
to allow you
program.
to scrub on the cases.
That's
and
right,
be the second assistant.
But it was worth it. I mean, you understand, if you're
Yes,
you're part of the procedures. And so I was doing cases with Dr. Brewster, Dr. Cambria, at that time, Dr. Abbott, and it was worth it. And you know what? The most important thing I learned, which is maybe hard to understand from a perspective of a resident. So I'm a resident in the Netherlands, and I'm doing surgery, vascular surgery. So you do bypass surgery in the aortas, and you do it the way you were taught to do it. And you say, well, this is it. and things go right, and sometimes they go wrong. Sometimes you struggle, and sometimes it works. And you have this picture of this famous American institution where vascular surgery was like the top notch of the world. And you would go there and they would teach you how to do vascular surgery finally, and you would see this revelation of wonderful surgery and everything would go right. And that's, of course, the reality is, once I was there, even though this was the Mass General and the big operations and big procedures, in the end, the procedures themselves were exactly the same
Is
like at home.
What
I mean,
you've
it
been
was
doing before.
of course there were
Yeah.
pickups, there were scissors, there
Yeah.
were knives, and you cut,
Yeah.
and
There's
and
the
thing-
pro
you would
league, yeah.
struggle, and
Yeah.
things would go right, and things would go wrong. And of course, I learned a lot, and procedures we never did before. But it was, on one hand, sobering, but on the other hand, comforting to see that, like, surgery is this uniform thing. It's just people cutting people, which was very was a revelation for me.
At that point, you returned
Yeah.
to the Netherlands,
Okay.
and were you able to take any sort of a distinguishing examination, or
Right.
to say that you were a vascular surgeon at that point?
Right. So at this point, there were no vascular surgeons per
Mhm.
se in the Netherlands. It was surgery and people who had done their fellowships in vascular surgery would be general surgeons with an interest in vascular.
Mhm.
And the open positions for surgeons were always surgeon with an interest in vascular. But they would be general surgeons,
Mhm.
and they would be hired in a group of, well, anywhere between 3 and 6 surgeons
Mhm.
who would separate the patients a little bit, but when you're on call, you would do everything. So this was the early 90s, again, before the endovascular era. So most general surgeons were able to deal with acute vascular surgery.
Mhm.
Ruptured aneurysms, thrombectomies,
Ischemic legs. Yes.
that's about it, and maybe a little bit of trauma.
Mhm.
So pretty simple. And so when I returned, slowly things were moving in a super specialty in the Netherlands. And around that time, the Society of Surgery and the Society of Vascular Surgery in the Netherlands came up with a real certificate and a formal training program, much like the US training program, which was just a 2-year addition to the general surgery training.
Where you'd learn more about open operations and all about endovascular training also.
So endovascular was just not around at that
Mhm.
time.
Mhm.
It was just open vascular surgery. And since these trainings or vascular surgery specializations were not that formal, my US certificate, which was just a paper saying that I did this clinical fellowship at the Mass General, was enough to get me the approval to do vascular surgery in the Netherlands. So it's interesting to talk about endovascular surgery because I remember the word didn't even exist in '92. Endovascular, nobody used that word. When I left Boston, one of my last conversations, sort of goodbye conversation with Dr. Abbott, in his room, I remember vividly, and this is an interesting story because I remember sitting there and he was like leaning back with his feet on his desk like always.
Mhm.
And he would say, "So Jan, now you have Harvard on your CV. what are you going to do with it? And I never thought of that question, so I said, well, I'm going to go back to the Netherlands and practice vascular surgery. And I remember he threw, so this is June '92, he threw an issue of the Journal of Vascular Surgery at me and opened a page where there was an ad with an angiogram of an aneurysm. There weren't that much CTs. I mean, I don't know exactly the timing, but spiral CT wasn't really there.
Not yet, no.
So there was an angiogram of an aneurysm with a nice neck and anatomy. And the ad said, an ideal case for aneurysm repair. Right? Question mark. So I looked at it and I said, yeah. So what's the discussion? And he said, turn the page, turn the page. So I turned the page, and the other side it said, no, it's a perfect case for percutaneous repair. Right? Percutaneous. And I had no idea what that was all about. I mean, this again, '92 was.
It was the very beginning.
The very
That's the
beginning.
first time I ever heard about it too. Was 1992.
That's right.
Yeah.
So Wes Moore, at that time, was probably making his preparations for doing the first EVT graft, which was November '92, September '92,
Yeah.
if I'm not mistaken, with the EVT graft. And nobody really knew about that at the time, and not even Bill Abbott. But it was interesting that at that time, he sort of planted that little seed of. So I thought I knew vascular surgery, right? And at the time when I was leaving, he just said, well, there's this other little thing that you might want to
Learn
look
more
into.
about.
Look into. So I returned to Rotterdam, where I was trained, to the Department of Vascular Surgery with Hero van Urk, who was the chief of vascular surgery there, as a vascular surgery fellow. I mean, positions were hard to get, and it was not an official training program. It was just an addition again. For the first time, I made some money as a surgeon, so that was welcome. And it was an interesting time, but it was not challenging enough. I mean, it was just the same vascular surgery that I had seen for the past year at the Mass General, and in the back of my mind, probably the idea of the percutaneous aneurysm repair kept growing. And right at the time when there were a couple of job offers for me, one was in Rotterdam to stay there at staff, and one was in another town in Tilburg Community Hospital in the Netherlands as a vascular surgeon. Right when I was sort of contemplating what to do, academic or non-academic, I got a call from Bert Eichelboom, who was the chief of vascular in Utrecht at that time. It was early '93, who said he needed somebody to run this percutaneous, minimally invasive program for aneurysm repairs. And it turned out that he had been in touch, or he had been approached by people from EVT, their first commercially available endograft, early '93. He had, I think, he had engaged into the program with EVT of doing the first endograft in Europe. And he had created this project and this job for a young vascular surgeon who could just run that project for him. And that's where my Mass General period came in, and my call for money for the insurance company because he was at that time a referee for the Dutch Heart Foundation. So he had actually been instrumental in
Helping to pay your
helping me
insurance.
my insurance, and so I had to write this little report. So he knew about it, and he thought that I could be a good addition to his team. So this is how I started with the aneurysm project in Utrecht in September '93, to be exact. And in January '94, I think the first endograft in Utrecht was implanted, if I'm not mistaken.
Did you go anywhere to learn to do that, or did someone come and help you do it, or
Both.
Yeah.
So I remember at that time we went to Los Angeles to see Wes Moore, and EVT had his had their facilities.
They'd manufactured
Menlo
them
Park.
there, didn't they?
Yep.
In Menlo Park.
Menlo Park,
Yeah.
where we did animals and learned how to do these procedures. It was just simple tube grafts, of course, so very, very rudimentary. And I remember doing a couple of cases, and then we had a report that the hooks broke off. So this was 1 year or so after we'd started, and so the entire program collapsed, and of course everything had to go back to the drawing tables. And I remember even at that time, '94, '95, I was already writing grants to start a study to compare open with endovascular repair. It was way too early, of course. I mean, it was one device, the hooks were breaking off. But I mean, we just wanted to get something off the ground. The Netherlands had a good reputation of organizing randomized trials. There were specific government funds available to do that, like national multi-center randomized trials.
There always have been very good papers from the Netherlands.
Based on that?
Based on randomized
Money
trials.
for randomized trials.
Oh yeah, yeah, there always have.
So we signed up for that, and I remember it was like 8 or 9 or maybe even more grant proposals, but in the end we got that proposal. I think in '99 it was granted, the Dream Trial.
The Dream Trial.
Yeah, so
Right.
that originated from those first experiments in Utrecht. Yeah.
And so then you've been involved with the Dream Trial
Yes.
ever since the beginning.
Yes. So
essentially.
yeah, yeah. So the very very first grant submission must have been '94, '95. I mean, because I remember we had submitted the grant, and the hooks started to break. So we were kind of disappointed. Knew, of
And then
course, immediately.
Within about, what was it, 9 months, they had fixed that.
At the end, I think it was about a year.
Maybe a year, yes.
Because in January '95, our program started again.
And Victor Bernhardt, you
Yep.
remember, Victor Bernhardt was
Yep.
helping
Yep.
and was teaching people how to do that and going around. Did he come to,
Yep,
to
absolutely.
Holland?
He was always there.
Yeah.
With EVT.
Yeah.
And
He was a friend of ours. He worked in Milwaukee and,
Yeah,
and
yeah.
connections in Chicago. So.
Yeah, that's one of the people I from that time. I started long-standing relationships with all of these people that were sort of at the beginning of this. Everybody, I mean, I think it generates friendship if you start at something really new. Because if it's something that's already there, there's people who teach you how to do things. And so there's mentors and there's pupils. But here everybody was a pupil, right? Nobody knew what they were doing. So that started a small family. Yeah. Group of people who met, of course, at all the international conferences. And everybody had the same problems. Everybody stumbled, and I mean, it was an interesting time.
One of the criticisms of the FDA in the United States is that they're too compulsive about approving new products, whereas in other countries they can be used sooner. Do you think that's valid, or how do you see it from your
At
perspective?
that time, that was certainly true.
Yeah.
And one of the most important reasons the companies came to Europe, because there was virtually no FDA-like system in Europe.
Yeah.
Every country for its own.
Uh-huh.
And there were more strict and less strict countries. And I remember at that time there was this wonderful slide of a US-based company in the boardroom that had some medical device, and their question was, what will be our next step? Pigs, goats, or Europeans? Which was really the way it was at that time.
Uh-huh.
And so that's why I think these grafts came to Europe, and we profited from those really low barriers for US companies, putting medical devices in Europeans. It has changed. By this time, I think, on one hand, FDA doesn't really accept Europeans for US approval, market approval. And in Europe, the current notified bodies are, and the rules, the CE mark rules and everything is almost just as restrictive as the FDA is. So it's, I think that time has gone.
Do you also treat thoracic aneurysms, or
Yes.
do you do quite a bit of that?
Mhm.
And then are you interested in carotid stenting?
Not so much anymore.
Mhm.
I think there was this great move towards carotid stenting 10 years ago when all the trials started. But slowly it turned out that this was not going to be the great revolution as aneurysm and vascular aneurysm repair was. Of course, the difference between open carotid surgery and percutaneous is not that big at the outset. It's not a big operation.
Correct.
With high mortality. And there's risks involved with carotid stenting, and those risks are strokes, and strokes is what risks for open surgery. So the big trials, again, the NASA trial '92, so it was the same time when I left Boston, was carotid surgery really on the rise, based on those clinical trials.
Is there a fair amount of endovascular for lower extremity arterial disease in the Netherlands?
Yes, there is.
Yeah. Is that used quite widely?
It's used quite widely, and but mostly in the hands of the interventional radiologists.
Oh, I see.
Yes.
So the surgeons don't do as much of that?
Correct. Recently, the Vascular Surgery and Interventional Radiology Society signed an agreement that it was okay for vascular surgeons to do their own interventions. It wasn't that self-evident before that. Radiologists would do endovascular peripheral, and vascular surgeons would do the open stuff. That was the division for years. And of course, endovascular aneurysm repair sort of crossed those boundaries, because radiologists never were able to do that on their own. They participated in many centers, but never on their own. But they did do, of course, the percutaneous PTAs of iliac arteries at first, and then the stents, and then the SFA and everything. And they were quite effective in keeping the vascular surgeons away from that particular area.
What about cardiologists? In this country, cardiologists also are interested in the lower extremities.
Yeah. For some reason that never happened in the Netherlands. The same is true for carotids.
Mhm.
I know in this country cardiologists, interventional cardiologists are involved with carotids. That's just not the way it turned out in the Netherlands. I don't quite understand the reasons why. It has to do something with reimbursement, probably, or the cardiologists simply not having the referrals. So no, that the cardiologists, interventional cardiologists in the Netherlands, they are like 95% coronaries.
So, yeah,
That's it.
I see.
So there's only the competition with the interventional radiologists, and I would say that right now still 80% of the peripheral and the vascular procedures are done by interventional radiologists in their angio suites. And vascular surgeons don't have their own angio suites. Only a few, I would say. And some will have the option of using the angio suites of the interventional radiologist. 1 day a week or so they can do cases. But it's mostly in the hand of the radiologist still.
The vascular surgeons in this country have a hybrid room where you have fixed equipment in an operating room. Is that seen? Do you use that for your endo-aneurysm repairs, or?
It's coming.
It's coming.
Yeah. Mostly for the aneurysm repairs, of course. That's where hybrid rooms are really useful for. Of course, we have C-arms. I mean,
Sure.
for ages, and there are vascular surgeons who do their hybrid procedures, their peripheral hybrid procedures, in the operating room with the C-arm. And some vascular surgeons do it together with the interventional radiologist. You must understand that the way the Dutch healthcare is financed, in many hospitals, there is no money incentive for a certain specialist to do a case in his own department, as opposed to in the operating theater. So for the radiologist, it doesn't matter whether he's involved with this procedure together with the vascular surgeon or if he does it alone in terms of money. And money is, of course, a big driver of battles on indications.
A great motivator. Yeah, that's right. You have been recently involved with the Journal of Vascular Surgery as an editorial function. How important is that journal around the world to vascular surgery? Is it read by most European vascular surgeons or seen by them? Or?
Well, there's the world and there's Europe. I'd say it's the #1 vascular surgery journal in the world. There's the European Journal of Vascular Surgery. But they're both, of course, English journals. The problem is language.
Oh, I see. Oh, yeah.
And Spanish, Italian, French, German vascular surgeons tend not to read English journals. Not as easy as the Netherlands and the Scandinavian countries do. So the Journal of Vascular Surgery is big in the world. It's the leading vascular journal in the world. In Europe, it's probably at the same level as the European Journal, which is also in English, of course. And then there is the national journals, of course.
I wonder if there's a position for translating the Journal of Vascular Surgery into Italian and Spanish.
I don't know. Are you saying it's happening?
No,
or?
I wonder if there'd be if that would be a value to formally translate it.
I don't know.
Yeah. What about the vascular societies? Are you've been coming? You usually come every year to the SVS.
Yep.
Do many surgeons from the Netherlands come over every year?
I think it has gone down a bit. Yeah. And I don't quite understand the reason, but one reason could be that there is a number of high quality vascular surgery meetings in Europe that probably do the same thing for these vascular surgeons. So it's Charing Cross, the ESVS, and then maybe the EVC, European Vascular Course. And I would agree that if you go to any of these three meetings, that it's maybe not even necessary to add the SVS to that list. You're going to get repetition if you do all these meetings.
You had mentioned the Dutch Vascular Surgical Society.
Yeah.
Do you is there an annual meeting of that? Or?
Yeah.
Yeah. And then where are those papers published?
The Society for Vascular Surgery has a link with the European Journal of Vascular Surgery, and the Society of Surgery has a link with the British Journal of Surgery. So most of the papers go to the European Journal or the British Journal of Surgery.
What meetings do you go to in Europe on an annual basis?
So Charing Cross would be
yeah.
number one. Link in Leipzig has become one of the leading endovascular meetings in Europe. And then there is the European Society, which is more of a scientific meeting, much closer to the SVS, with formal abstracts and a review committee and an attached journal. And the EVC, as I said, is the European Vascular Course. It's good quality. So those are the main vascular surgery meetings in Europe. And here I would say FEED is a symposium which is very similar, not better or worse, but very similar to Charing Cross, with invited faculty.
Multiple topics.
Yeah, multiple topics, like a review of the latest of the latest. Whereas ESVS and SVS are more the scientific-based meetings.
What do you think about the international chapters of the SVS? That there are 6 or 8 of them now. Is that of value around the world?
I don't know. I think it's not a big thing in the Netherlands. There is a few surgeons who are a member of the International Society, but it's certainly not a strong force in the Netherlands. And I know that the ISVS, which Frank Feet started, when he started it was mostly it was something that needed a political force. It was not so much a scientific society, more of a
sort of an organizational gathering.
Yeah, more for the vascular surgery, the vascular surgeon's interest, right? For the specialty vascular surgery, and there's a lot to say on getting support from various countries and defending the values of vascular surgery in those countries together with vascular surgeons from other countries, because like in Europe, there are all these small countries where vascular surgeons are just a very small group with very little say. So a stronger international organization
Could help
would
that.
help,
Yeah.
promote vascular surgery.
surgeries.
Yeah.
Where, the training of vascular surgeons is evolving, and part of it is because of the emphasis on endovascular, where it's harder to train people to do open surgery and a lot of endovascular. Other things are that we have work hour restrictions here. We're interested in getting more women into vascular surgery. Any thoughts on that? Any ideas that you have?
Well, I think the situation in Europe is still lagging behind relative to the U.S. And one reason is, of course, the separate countries make it harder to continue to progress to subspecialization. As I said earlier, in the Netherlands, we still don't have a specialty called vascular surgery. It is a subspecialty of surgery from a legal standpoint. We're surgeons. And that needs to change because the business of vascular surgery has changed dramatically over the past 2 decades. And we're still training these people as if they are general surgeons with an interest in vascular, which frustrates me because again, if you want to become a vascular surgeon in the Netherlands, you go into general surgery and you start doing appendectomies and gallbladders and laparoscopic surgery and trauma surgery, and I mean this needs to change.
We have the route now from directly out of medical school, which
Yeah.
is new for us too, but is working quite well.
Well, I remember, and correct me if I'm wrong, that when this was engaged, there were 3 or 4 separate programs, 3 or 4 separate options for anybody who came out of medical school in the US, where he could choose for either like a mixture of 5 years and then 1 or 2.
Basically,
or
there's the 5 years of general surgery, 2 years of
Yeah.
fellowship training, and then there's what we call the 0-5, where
Zero
you
five,
come
yeah.
directly out of medical
Yeah.
school and spend 5 years.
Yeah, and it turned out,
Yeah.
and initially there were these options, and I understand that quickly people started to prefer the 0-5
yeah.
option. So in the end, it's the market really that drives
That's true.
the
Yeah.
specialization.
Yeah.
And I think it was a clever decision to have these 3 or 4 different options and to allow the market to show what people wanted. And in the Netherlands and in many European countries, we still don't have that. We don't have vascular surgery training, 0-5 type of options. I know in Spain, I know in Italy and Germany, not in the Netherlands. And that would be, in my perspective, one of the most important things, one of the priorities of changing the training programs in the Netherlands. So people can go directly into a vascular surgery training program.
What about the dilemma of training people to be good open vascular surgeons?
I tend not to think in these alleys of open and endovascular and percutaneous, and it's vascular disease we're treating, and whether you use a knife or a needle and a catheter, it's all pretty much the same. It's treating vascular disease with your hands, and whether you're using a knife or a forceps or whatever, a catheter is somewhat the same. We need to treat these surgeons to treat the vascular disease by any way they can. Now, having said that, open surgery, of course, gets less and less. And it's a real challenge nowadays to train vascular surgeons in open bypass surgery, in open aneurysm repair, because there isn't that much around for these.
That's right.
Sure.
And maybe it's an interesting transition, because when endovascular came around, initially people would say endovascular needs to be done in the big university hospitals. Oh, endovascular was so complex and it was so new and involved so many new things that could go wrong. People thought this is how it's going to be. Open vascular surgery is in the smaller community hospitals, and endovascular is in the academics. Now, soon enough that changed, and endovascular, of course, was spread out over the country. Everybody does endovascular aneurysm repair. And we, in a university hospital, we hardly do any infrarenal EVARs, because they're done in the community hospitals. So now what we're getting is the fenestrated, branched, and the suprarenal, and the thoracic, and the dissections, and the complex stuff. I think the same thing will happen with open repair, where we thought this would be in the peripheral hospitals. There will be so little open repair in the smaller community hospitals that this is probably going to move to the bigger hospitals. We see many hospitals and departments fusing simply because of the numbers, because they don't have enough open aneurysm surgery. 3 or 4 bypasses a year, that's not enough. So it's centralization.
Yeah.
So the bigger centers are going to do open surgery, and I really believe that in the end we will be training vascular surgeons in these larger centers.
Can you think about ways that the Netherlands and the United States could cooperate in training surgeons, or better through our societies, or
So you mean exchanging?
exchanges? You had
Yeah.
a lot of success and fun with that earlier in your career.
Yeah. Well, I think it's easier to get Europeans and Dutch surgeons to train a part of their training in the US than the other way around. And I realized that when I was open for US vascular surgeons to come over to the Netherlands and train, there is a reluctance with young surgeons in the US to go abroad. Not everybody wants that. I mean, it's a different culture, it's different language, it's all these scary things. I learned that many American surgeons don't really like to go somewhere else. So that needs to be dealt with first. And the other way around, there are these liability issues with the current medical practice in the US,
Right.
which of course I experienced really early in my career.
Well, you have to have a license,
Yeah.
essentially, to come and really participate as a fellow.
Yeah.
You have to have
Yeah.
a license.
Yep.
You do. Yeah.
And so I think it would be nice, but there are a lot of practical.
Yeah. Tell us about any sports or hobbies that you're interested in.
Um, well, sports, it's very hard to maintain some sort of team sport when you're a surgeon in training, or I mean, it just does not fit into a standard surgeon schedule. So it's always the individual sports. So I ran a couple of marathons. I ran the 100th Boston Marathon. So this was 2000. So when was this now? Probably 98, I guess. Yeah, 1998
Did you?
was in the
15
100th
years
Boston
ago. Uh-huh.
Marathon. Yeah, and this was exactly on the same day as last year's or this year's Boston bombing. Yeah. So sports. So nowadays it's mostly a little running and individual sports that what we end up with. My most important hobby is music. So I play the guitar, and that's been in the attic for a while during my surgical training. But just a couple of years ago, I picked that back up, and I'm a very enthusiastic guitar player. With myself, with the current technology allows you to very easily tape and make music, but also with others in playing in bands and yeah,
Great.
a lot of fun.
What about your family?
I have 3 children, 2 from a previous marriage, 2 girls. One is already in medical school in the Netherlands, and the other one is still in high school. My wife is a general practitioner in Utrecht, and we have a 7-year-old son.
Great.
Is your daughter going to be a vascular surgeon?
She is, interestingly enough, now involved in a liver transplant program,
Sure.
which was totally out of the blue.
You have to revive your thesis.
Exactly, and so she's now working together as a medical student with the people I trained with back in Rotterdam when I did my transplant studies. So it's interesting how small the world is and how people keep crossing your path. So no, she's not even like myself. I was already convinced I would become a surgeon when I was 12. She's not like that. Maybe it's very typical for the younger people. They like to keep their options open. Yeah.
Well, Jan, thank you very much for coming.
It was my pleasure.
Yeah.
Thank you, Walt.
I would like just to ask few questions.
Sure.
if I may. What's your thinking about American in the eye or Europe about our vascular surgery status?
Mhm.
You know, the FDA approval for medical device in this country is
Yeah.
takes so long.
Yeah.
We are so behind.
Yeah.
All the company are moving to Europe, to South America, and we are losing a lot of ground on this.
Yeah. Yeah, it's an interesting, strange combination, really, when you think of your comments this morning on the video, where you were asked by Dr. Gregory, I think, what made you excel? And your answer was, it's America. If you work hard, you get rewarded. And it's interesting because you have the possibility with the technology and the way, exactly for that reason, business works. If you develop something, you get your money somewhere, you
You get it
develop
out,
it.
yeah.
I mean, so it's a land of endless possibilities. And then there's this strange limitation that you have as physicians, as surgeons, to for some reason not be easily available for these companies to get their materials
Yeah.
tested.
Yeah.
So, as you say, that works against the vascular surgeons in the U.S. So I understand, of course, there is the patient safety involved, but if you drive this thing too far, you at the other end limit the possibilities of developing new technology where people could, of course, benefit from. And that is, in my mind, your limitation, your unfortunate situation. I wish that was a little bit different.
Recently, in United States, there are more interest in venous disorder. Is that happening in Europe?
It happens, but again, this is very much money driven. And it used to be like nobody was very interested in venous surgery because it wasn't really vascular surgery. It was community hospital vascular surgery. And then came these new technologies about, and these companies driving these treatments. And very much like here in the Netherlands, there was this money incentive in private clinics of treating venous problems with these machines, and this has created a tremendous interest in venous surgery. Not only the simple money things, but also research. And I think that is something that came out of this. Bigger series are done, better scientifically based studies are done on venous repairs, and that's what's gonna be, that's the yield, I think, of this.
With the merger of IS, CVS, and SVS, the international exchange certainly is a little bit different than when we have International Cardiovascular Society.
Yes.
SVS at the moment are very interested to improve the international relationship. We have the international committee. We are doing the international membership. We have international scholar program for young people to come. Would you support your young people to come to the scholar program?
Absolutely, absolutely. I mean, I'm one of the examples of people who base their careers on international fellowships, and I think it's extremely helpful for European and specifically Dutch vascular surgeons to be able to be trained abroad. And the Vascular Surgery Society, SVS, was kind of contained for many years. It was really just an American deal. So I would applaud opening that up a little bit for international surgeons.
Well, thanks for coming for the interview.
Thank you, Dr. Yao. Thank you very much.
It's been very helpful to us.
My pleasure.
Yeah,
Thank you.
It was great to talk to you.